GLP-1 receptor agonists are a new drug modality to treat people with type 2 diabetes and obesity. They work by stimulating beta cells in the pancreas to produce insulin, very similar to how insulin used to work, except a little bit more holistic. It delays gastric emptying, it stops the production of glucagon and stimulates the insulin, thereby reducing blood sugar levels in those with diabetes and also with obesity. It also functions in the brain to reduce appetite, which is part of the mode of action. An oral format gives more options to the user. We're moving from the treatment of traditional type 2 diabetes, where patients normally do see themselves as patients, and acceptability with needles is a little bit higher. As we see this new use in obesity, and people are less willing to go for injectable formats, and it really does offer added options to clinicians trying to treat their patients, and to give the patients more offerings, and to potentially give people who have needle phobias or other dislikes of needles an option which suits them. So traditionally, we focused on treating diabetes by focusing on blood sugars. GLP-1 receptor agonists are a much more holistic way of treating the disease, where insulin was a convenient option because it has almost instant feedback on blood glucose levels. It isn't a disease-modifying therapy. Glucose receptor agonists give an option where you don't need immediate treatment. You can take weekly injections, and your body will naturally respond to high sugar meals and produce insulin itself. The breakthroughs really were related to work done by Novo Nordisk over the last 10 to 20 years, where they worked on GLP-1 receptor agonists, and they found that they could change the half-life of this protein from seconds to minutes to something which lasts for hours in the bloodstream, and that made it a potentially effective drug candidate. There's a massive need for more options for patients with diabetes and obesity in the GLP-1 receptor agonist space. There has been a global shortage for the last 1 to 2 years, driven by manufacturing constraints. So more options will potentially increase supply. And we're hoping to also develop an oral option with enhanced bioavailability, meaning that the amount of drug that we would have to dose patients is potentially lower. So again, counteracting that supply constraint and also offering patients more options. So the small intestine is where the body takes up most of the nutrients that it's delivered. But where we ingest macronutrients, these normally need to be broken down into micronutrients like glucose, vitamins, and small peptides that are 1 to 2 to 3 amino acids in length. But we do also know that the small intestine can take up larger amino acids or larger peptides, about 50 amino acids in length. This was going back from research in the 1990s, where insulin was successfully delivered orally. The challenge has always been in creating a drug delivery technology which can effectively and reliably do this every time. So the technology that we've licensed from Anabio, which was developed by them over the last 1 to 2 decades, is all about protecting peptides and delivering them to the gut. So we do this by forming a tight seal with generally regarded as safe components. And this is important in 2 elements. One is during the manufacturing process, we can protect the protein. And the second is during the ingestion process, we can protect the protein as it travels through the stomach, through the upper small intestine that are characterized by an acidic environment, and releases the API into the gut where it can be taken up safely.